Yes. Assalamu alaikum wa rahmatullahi wa barakatuh. Ladies and gentlemen, good morning, good afternoon, good evening, wherever you are. Welcome to the heart failure webinar session. My name is Mohammed Al-Harari. I'm a cardiologist and currently holding the position of the chair of the heart failure group of the Emirate Heart Society. This is our second virtual meeting for this year. The theme of this meeting is advanced heart failure. I promise you, we have 3 distinguished speakers. You will enjoy the session, guarantee. You will learn a lot. I'll learn a lot. This session is sponsored by the Johnson & Johnson. Just give you a couple of housekeeping points before I introduce the first speaker. First, for the questions, there's no facility for you to speak, so you need to write all the questions in the chat box, and they will be forwarded to us, and we'll answer them all. The second thing, just at the end of the session, you need to fill in a survey that will be put on the chat in order to get the CME points. So moving forward, it's my great pleasure and honor to introduce our first speaker, my friend and colleague, Dr. Kamil Lawati. He's a consultant cardiologist with advanced heart failure in the National Heart Center in Muscat, Oman. He done all his training in the Queen Elizabeth Hospital in Birmingham. It's cardiology training. He's currently run the heart failure service and the devices and the National Heart Service, and mostly in the process of getting the place developed to better and better. Tonight he will talk to us about choosing the best medical therapeutic options in advanced heart failure. Kamil, the floor is yours.
Thank you very much, Mr. Chairman, for this nice introduction. I'm delighted to be tonight in this event, and I'm sure that you will learn a lot from my presentation. I am very excited, actually. So I'm going to talk about the best therapeutic options in patients with advanced heart failure. So as a start, it's just a brief review for the audience about the definition of heart failure. So as you know, now we are defining heart failure as a syndrome. And by that, we mean that the patient has to have typical symptoms like breathlessness on exertion or easy fatigability that might be accompanied by signs like raised JVP or S3 on auscultation plus crepitations. And we need to demonstrate that this is caused by structural and or functional cardiac abnormalities that results in reduced cardiac output and or elevated intracardiac pressures. This can be at rest or during stress. Now, the ACC has similar definitions. They just incorporated the BNP in their definitions. I also want to remind the audience that we classify heart failure now into 3 categories. Heart failure with reduced ejection fraction, where the ejection fraction is less than 40%. Heart failure with preserved ejection fraction, when the ejection fraction more than 50%. And heart failure with mildly reduced ejection fraction, which is between 41 and 49%. And this is very important to know because we can have advanced heart failure across the whole range of ejection fraction, not necessarily when the ejection fraction is below 30%. So when we talk about advanced heart failure, we usually talk about those on stage D heart failure, when they have persistent symptoms despite optimized medical and device therapy. And typically those patients are in NYHA class 3 or 4. Now the ESC has strict definition for advanced heart failure. They made this nice criteria. If you read it, all of it, the endpoint is the patient has very low oxygen delivery to tissues. And that's the thing that you need to tackle in advanced heart failure. So those patients has to be on optimal medical therapy. And if despite that, they have severe or persistent symptoms, they have severe cardiac dysfunction, not necessarily ejection fraction less than 30%, but also isolated right ventricular failure or heart failure preserved ejection fraction when you have increasing BNP and severe LV diastolic dysfunction or structural abnormalities. You also need to have multiple admissions with pulmonary or systemic congestion requiring high dose IV diuretics, or episodes of low cardiac output requiring inotropes or vasoactive medications, or malignant arrhythmias like VT, which can cause more than one unplanned visit or hospitalization in the last 1 year. We need to objectively test those patient functional capacity. So we put the patient on treadmill, and if the oxygen consumption is less than 12 ml per kg per minute, or less than 50% of predicted value, or if you don't have CPEX in your setting, you just make the patient walk for 6 minutes, and if it's less than 300 meters, then you have advanced heart failure. Now, when we talk about advanced heart failure, we move from NYHA classifications to the Intermax classifications. The worst thing is Intermax 1, when the patient has critical cardiogenic shock, and the best thing is 7, note the patient has advanced symptoms, but is still ambulatory. Usually when the patient are referred for advanced heart failure therapies, they usually are having recurrent decompensation, then they are in Intermax class 4 when they are listed electively, or they're inotrope dependent when they need to be under urgent transplant list. Now, when the patient come to us, we classify their hemodynamics. The best thing you get is warm and dry, and the worst is cold and wet. And our goal to achieve is maintenance and correction of water status by diuretics, improve perfusion, and start GDMT as soon as hemodynamically feasible. Now, you might think that by definition, there must be a GDMT, but practically talking, it's very difficult to pinpoint who is refractory. A lot of patients comes to us, we think they're advanced, we put them on IV diuresis and IV inotropes, but we are able to wean their inotropes and diuretics and put them on small doses of GDMT as soon as feasible. And then we discharge them, and they come back to the clinics and they are fine. So always put in your mind, GDMT are cornerstone in treating patients of heart failure. So put it on board as soon as possible. Over the past decades, the treatments have evolved a lot, and the discovery of RNA and SGLT2 inhibitors made a huge positive impact on our clinical practice. But despite that, the morbidity and mortality are quite high. Just a brief thing about pathophysiology so we understand the medications. In those with a heart failure, they have high angiotensin II, and that through angiotensin I receptor will cause aldosterone secretion, vasoconstriction. It will increase your afterload, make fibrosis in the heart, negative remodeling, and all these things. You also have high aldosterone levels when it causes sodium retention, causing volume overload, potassium, magnesium loss causing arrhythmia, and then it causes myocardial fibrosis and endothelial cell dysfunction, and that will cause for you negative remodeling, or what we call it pathological remodeling of the heart. We also know that they have high sympathetic activity, and in this work in 1984, we know that if you have high plasma neuroepinephrine level, your survival goes really down. And that's why beta blocker helps. Now, throughout these years, there are multiple clinical trials that have been on board since the 1985. We have the consensus and SOLVE treatment that tested the ACE inhibitors. We then had the MERIT, CBIS, Copernicus seniors that tested the beta blockers. We had RAILS that tested the spironolactone. And then we have the ARBs through the CHAM and VAL-HF trial, testing valsartan and candesartan. Then the emphasis trial came for eplerenone. In 2014, Paradigm HF made a huge impact and made a big difference in managing these patients. And then in 2019, we have the DAPA-HF, and in 2020, the Emperor reduced, which showed that SGLT2 inhibitors have a great positive impact in treating those patients. So ACE inhibitors are recommended since 1997, and the CHAM alternative trial provides evidence that ARBs are good alternative to ACE inhibitors, and Paradigm HF trial showed that sacubitril valsartan is superior to ACE inhibitor and causes further reduction in morbidity and mortality. So those are the clinical trials for the beta blockers. So CBIS was for bisoprolol, MERIT was for metoprolol, Copernicus for carvedilol, and they all showed reduced all-cause mortality. And there was a doubt whether we can start beta blocker in the elderly. And then the seniors trial came and showed that nebivolol is safe in those more than 70 years old. Not only that, we have a trial called the MOCA trial that showed the dose response effect of carvedilol in terms of LV ejection fraction improvement. and reduction in mortality and hospitalization, pinpointing the importance of up-titration of carvedilol in these patients. So the evidence of MRA came from RAISE and EMPhASIS HF trials, though there is no convincing dose-response effect of MRA more than 25, but the ESC and the ACC recommend up-titration to 50 milligram OD if no hyperkalemia. As I said, the DAPA-HF and EMPEROR showed positive effect of SGLT2 inhibitors, and the meta-analysis of these both trials revealed 13% decrease in all-cause mortality and to 45% reduction in composite of recurrent heart failure hospitalization or cardiovascular death. Now, the question is how to implement this medication, simultaneous or stepwise? Now, I want to tell you that we shifted from stepwise to simultaneous because we know that the effect of this medication is additive and it is independent of the other medication. You don't need to be on ACE inhibitors first to start the beta blockers or ACE plus beta blocker in order to start spironolactone. We know from the registries and sub-analysis that if we put all of them together, then that will be a much more greater benefit than individual ones. And this was also being tested, and this paper by Trump, J et al. In JACC showed clearly that if you use the all four ARNI plus beta blocker plus MRF SGLT2 inhibitors, it causes the greatest reduction in all-cause mortality. So rapid implantation and fast up-titration is the key as early as 2 to 4 weeks after start, and it's much more superior than the more gradual approach. And there was a landmark trial called the STRONG HF trial, which showed that high-intensity rapid up-titration and close follow-up treatment group had less mortality and hospitalization compared to those who were in the usual care group. And not only that, the study procedure was very interesting. The high-intensity group received half doses of GGMT at hospitalization with up-titration to target dose after 2 weeks. And there were very favorable results, and serious adverse events were only similar between the two groups. However, this study is an open-label study, and this strict regimen may not be applicable for all the centers in the world. That's why you need to modify it according to your logistics. The key is that all on board, fast up-titration, rapid implantation. This was addressed by Packer and McMurray, and they proposed a very nice policy by starting beta blocker and SGLT2 inhibitor first. So beta blocker because it reduces sudden cardiac death, plus the morbidity and mortality, and plus SGLT2 inhibitors because they don't have much impact on blood pressure. And then you see the patient in 2 weeks, and you either use mineralocorticoid receptor antagonist or ARNI, depends on what's available. And the message here is that rapid initiation with low doses is much better, and the patient has to be on all foundation drugs as soon as possible. And I want to emphasize here that hospitalization is a key moment to optimize medical therapy. Okay, it's a nice study by Rao et al. Showed that among patients eligible for therapy, if you discharge them without medication, then this is associated with more than 75% chance that they will not be saved in 1 year. And that will impact their mortality and morbidity. So use the hospitalization to start the medication and up-titrate them up to what they can tolerate, because you know the blood pressure will be soft at that time. You might not give them the full doses, but at least a small dose and whatever they can tolerate before they get discharged, and implant a strategy and policy in your hospital that you can see them as soon as possible to up-titrate their medications. But can we start the new drugs during hospitalization? And the answer is yes. And the Pioneer HF trial, which aimed to assess efficacy and safety of initiating Entresto in patients hospitalized with heart failure after stabilization, showed clearly that if you started early after stabilization and before discharge, there'll be much more reduction in NT-proBNP and lower rates of hospitalization at 8 weeks after randomization compared to those who were on enalapril. Not only that, there was reduction in troponin concentration, and the adverse events were similar between the two groups. The same about the SGLT2 inhibitors. So in EMPAS trial that tested empagliflozin, it showed that the initiation of empagliflozin as part of usual care in patients who are hospitalized for acute heart failure will result in clinically meaningful benefit in 90 days without safety concerns. And here, just to say that the ESC have moved from the stepwise approach to the simultaneous approach. So what next? So if your patient is still symptomatic, as in sinus rhythm and heart rate more than 70, consider ivabradine. If the patient have left bundle branch block and the QRS is more than 150 and is still symptomatic, then get the patient to electrophysiology clinic to get CRT implanted in him. If the patient has atrial fibrillation, then refer him for AF ablation. There was a recent study published recently showed that AF ablation in those with advanced heart failure who have persistent atrial fibrillation, if we are successful in reducing the in converting them to sinus rhythm, then they will be much better symptomatically and they remove them out of transplant list. So consider that. And if patient has symptoms despite moderate, if the patient is symptomatic despite optimal medical therapy and has disproportionate moderate to severe MR, then consider MitraClip. That will greatly reduce their morbidity and hospitalization if they fulfill the co-opt criteria. So despite what we have done, especially with the medical therapy, there will be some patients who will be having recurrent decompensation and they will be unfortunately inotrope dependent. Those patients will have low cardiac output and marginal low blood pressure, and those patients impose a real challenge and a nightmare. It will be necessary to use inotrope in this patient to improve symptoms and enhance an organ perfusion, but we need to balance the hemodynamic benefit against the increased mortality and morbidity that have been shown with using the inotropes. So the ESCAPE trial showed that in-hospital use of inotropes is associated with higher risk of death and rehospitalization at 6 months. And then when levosimendan came, the REVIVE-1 and REVIVE-2 studies still did not show their superiority. It's also associated with increased mortality, hypotension, and tachyarrhythmia. What I need to point here that if the patient needs inotrope, then give them inotrope, but you need to individualize your treatment, do right heart cath, and try to tailor the inotropes to the patient hemodynamics, and use the inotropes with the low dose possible and less duration possible. Now, these are the list of a table of the inotropes that we use. We usually now don't use much epinephrine. We use more of dobutamine, norepinephrine, and milrinone. We usually start with norepinephrine first. This is very variable between different centers. This is probably my practice, because when you use dobutamine initially, you get hypotension. So I used norepinephrine to stabilize the perfusion, and then give dobutamine, and then I wean off norepinephrine. Now, a lot of patients will have high pulmonary pressures, and those who have high systemic vascular resistance, I use milrinone in this patient because it has vasodilatory effect. Levosimendan is a calcium sensitizer. It's a good inotrope. It's not a vasoconstrictor. It has some vasodilatory effect. And the problem with levosimendan is it is a very expensive medication. So it's not available everywhere. It's not available at our center. So what are the clinical scenarios? So the patient who are on inotrope, there are one out of these 4 clinical scenarios. One of them is congestion refractory diuretic therapy. In those patients, they will be congested and they have low blood pressure. So you need to stop their medication, give some inotropes to perfusion. Plus, they have a lot of congestion. So because of this congestion, they will have severe TR and severe MR, and this enhances your congestion, and they will be in vicious cycle. So in those patients, use short-term inotropic support to combat this vicious cycle of low perfusion, persistent congestion, and diuretic resistance. And now milrinone and levosimendan may increase urine output, but the evidence is not very great. Some of the patients will be having advanced heart failure with end organ damage, and we need to know whether they are accounting for LVAD. Now, if you have very severe end organ damage, then those patients are not a good candidate for LVAD, but a lot of patients, this damage is due to their cardiac condition. So you give them inotrope and diuretics, and you can find that there will be some reversibility in their condition. The GFR increases, the bilirubin comes down, and those patients can be assessed for LVAD and transplant. Some patients who are already been tested and they are being listed for LVAD, we need to put them on inotrope to optimize their hemodynamics before the LVAD, and we regularly assess their hemodynamics before they get their LVAD implanted. Some patients comes to you and they are getting advanced heart failure, and you anticipate very short waiting time. It's better for them to be bridged to transplant by inotrope rather than going to LVAD and then transplant. So less patient will be in the last category, but it's something to consider. So we talk about inotrope dependence. So what is the criteria of inotrope dependence? So how can we say that the patient is inotrope dependent? If you fail to wean IV inotrope support within 72 hours without development of symptomatic arterial hypertension or without worsening of renal hepatic function, defined as eGFR decrease more than 30%, or clinically important elevation in liver enzymes, or INR, or worsening of congestion leading to or upholding NYHA class 4 symptoms. So you are unable to wean them. If you wean them, they will get symptomatic hypotension, they will get recurrence of end organ damage, they get worse congestion. So these patients are, we classify them as having inotrope dependent if you are not simultaneously introducing or uptitrating beta blocker or RAS inhibitors. So if you are weaning off and you use beta blocker or Entresto or, for example, lisinopril, and because of starting beta blocker or lisinopril, they are having an organ damage, they are still not classified in inotrope dependence. So if they are solely on inotropes, and by reducing inotropes, they are getting all these bad clinical outcomes, then they are inotrope dependent. A lot of patients asking about management of GDMT during inotrope support. We have very difficulty answering this question because the evidence is really very scarce for safety and for efficacy. Often such patients don't tolerate neurohormonal blockage due to circulatory insufficiency and coexisting end organ dysfunction. However, if you get this patient on ambulatory inotropes, so inotropes as OP setting, okay, or they have intermittent infusions, so GDMT should still be considered as a cornerstone for their management, but you might use a very, very low dose, or you might temporarily stop the medications to allow the inotropes. So in summary, so heart failure is a malignant condition with high morbidity and mortality. Achievement of a dry warm state is desirable. Early initiation and rapid uptitration of GDMT is important to meet the best outcomes. Use CRT as soon as possible in those who have LBB. Inotrope has a lot of limitation and should be used as a last resort and should be reserved for temporary stabilization of selected patients with rapidly deteriorating hemodynamics or treatment refractory heart failure who don't tolerate vasodilators. Those patient mechanical support may be important, and I have this continuation of this talk to my co-speakers. Thank you very much for listening.
Dr. Kamel, that was really great, and I think it's a good introduction for the next talk. And as I said, we leave the question to the end. So it's my great pleasure to introduce Dr. Emil Najjar. He's a consultant cardiologist. He's the medical director for the ventricular assist device program in Karolinska University in Stockholm, Sweden. He's a clinical researcher. He's supervising a lot of PhD students. He has a lot of publication. He has got many boards in addition to the European Heart Failure Board, the echocardiography, the Swedish Cardiology Board. And I don't think we'll get a better speaker than him to talk to us about the treatment options beyond medical therapy in advanced heart failure. Dr. Emil, the floor is yours. Welcome.
Good evening, everybody, and I'm really honored to be invited to this meeting. Thank you, Dr. Mohammed and the organizing committee. Today, I'm going to talk about treatment options beyond medical therapy in patients with advanced heart failure, and some of my slides are have already been shown by my colleague, but let me talk about the different options that we have. These are my financial disclosures, and I'll talk about advanced heart failure from the definition to epidemiology, diagnosis, prognosis, and I'll talk about 4 management options, including mitral clip, mechanical circulatory support, transplantation, and palliation. First of all, different terms are used in the literature when we talk about advanced heart failure. So sometimes we see advanced heart failure, sometimes terminal heart failure, other times end-stage heart failure, or refractory heart failure, or stage D heart failure. All of these terms mean the same thing, which is advanced heart failure. And advanced heart failure is defined as an advanced stage of heart failure characterized by severely limiting symptoms with hemodynamic impairment, frequent hospitalizations, and of course, it's associated with high mortality. And as my colleague told you, the Heart Failure Association presented 4 criteria to define advanced heart failure. And these criteria include, number 1, we need to have a patient with severe symptoms of heart failure, NIHA class 3 or 4. We need to have severe cardiac dysfunction, and this includes HFrEF and HFpEF. Number 3, the patients need to have congestion, pulmonary or systemic congestion. And finally, they have to have severe impairment of exercise capacity. And if we use the different staging of heart failure to define advanced heart failure, you'll see that the ACC stages, in that staging, the stage D is the one with advanced heart failure, while in NIHA classification, we usually talk about NIHA class 3B or 4 to define advanced heart failure, while Intermax profiles were originally designed to describe patients who got left ventricular assist devices in the US. And in Intermax profile, when we talk about advanced heart failure, we usually talk about profile 1, 2, 3, and 4. But 1 and 2, they're usually acute advanced heart failure, while 3 and 4, they are chronic advanced heart failure. So stage D in the ACC stages, NIHA class 3B or 4 in the NIHA classification, stages 1 to 4 in the Intermax profiles, but I will mainly talk about 3 and 4 because 3 and 4 are chronic advanced heart failure. And what we know about heart failure in general is that it's a progressive disease. It will worsen with time, and you'll see this gray window. This gray window includes patients with advanced heart failure, which we need to identify, and then either to escalate our therapies and go to advanced heart failure therapies like left ventricular assist devices or transplantation, or we may decide that there's nothing to do and we have to go to the palliative care. So the gray window includes patients with advanced heart failure that we need to identify. And the next question is, how many of our heart failure patients do have advanced heart failure? What we know from the heart failure epidemiology is that the prevalence of heart failure, the picture on the left side, what we know is that the prevalence of heart failure increases with increasing age. On the right side, you will see that the projected prevalence of heart failure between 2012 and 2030 is increasing. So the heart failure is becoming more common and the prevalence is increasing. And we really don't know how many of these heart failure patients will develop advanced heart failure. There are some studies that have shown that probably it's between 5 to 10% of all heart failure patients will develop advanced heart failure. And this is one of the few studies that studied patients who were referred to a university hospital taking care of advanced heart failure patients. And this study showed that about 5% progress to advanced heart failure each year. And advanced heart failure is associated with high mortality. But what about the mortality in advanced heart failure? Well, there are a number of studies that have tried to answer the question, the mortality or the prognosis associated with advanced heart failure. And on the left side, you will see the REMATCH study, which is the only randomized study in left ventricular assist devices that compared patients with LVAD in addition to optimal medical therapy in comparison to those with only medical therapy. This study was published in 2001, and you see on the left side that the mortality in the medical group was only 8% at 2 years. This means that in that cohort with advanced heart failure patients, they were really sick and the mortality was really high. On the right side, we'll see the survival in the different Intermax profiles from the Intermax registry. And you see those patients in the red line, the Intermax 4 advanced heart failure chronic patients, they have high mortality in comparison with 5, 6, and 7. So the mortality associated with advanced heart failure is really high. How do we predict survival in patients with heart failure in general? We usually use different predictors to predict prognosis in heart failure, like New York Heart, the NEHA classification, like the ejection fraction, the QRS duration, the exercise capacity, and many other predictors. Those who are referred to us, we usually use the heart failure survival score, this one, with 7 different predictors, and the Seattle heart failure score, and the MAGIC scores. These are 3 common scores that combine different predictors to predict survival in patients with advanced heart failure. And we usually use them when we see a patient with advanced heart failure. And if you look at the management, if we look at the management of the heart failure in general, you'll see that the ESC recommendations, they usually recommend the use of the optimal medical therapy, of course, but some of these patients will progress to advanced heart failure. In these patients, you should consider doing something for the mitral regurgitation, or you may consider patients for heart transplantation, left ventricular assist devices, or sometimes you give up and go to the palliative care. Let us talk about the details. The ESC guidelines presented a suggestion of an algorithm how to manage patients with advanced heart failure depending on the Intermax profiles. I will not go through the details, but you see that it depends on which Intermax. Those in Intermax 5, 6, and 7, they're stable. They are not too sick to be considered for the advanced heart failure. So when it is the right time for clinicians working in centers not taking care of advanced heart failure patients, when it's the right time to send these patients for a transplantation or LVAD center, to consider doing TEER for the mitral regurgitation, or left ventricular assist devices, or transplantation. Choosing the right time, the ideal time for referral is really important, because if you wait too long, the patient will be too sick to get benefits from the TEER or the LVAD or transplantation. On the other side, if you take patients who are really not that sick, like in Intermax 5, 6, or 7, the risks with TEER or LVAD or transplantation are much higher than the benefits of these procedures. So when it's the right time to refer patients to advanced heart failure center, we usually think of a number of clinical clues to clinicians elsewhere, like frequent hospitalizations, like frequent ICD shocks, like diuretic resistance, hypotension, and the patient no longer can tolerate the heart failure treatment, developing low sodium levels. These are some of the clinical clues to clinicians to find patients with advanced heart failure and send them further for advanced heart failure therapies. And the MCS guidelines presented I need help algorithm or table to remember when it's the right time to send patients, like being inotrope dependent, have severe symptoms, worsening of kidney function or liver function, hospitalizations, and so on. I need help for the clinicians. But two big names in advanced heart failure, Finn Gustafsson and Mandeep Mehra, they presented only the rule of 3. Instead of I need help with many clinical clues, they decided to have only 3, including frequent hospitalizations, increasing diuretic requirement, and the patient develops hypotension and intolerance to neurohormonal therapy. So if you need to remember one thing, remember the rule of 3. Let's talk about functional mitral regurgitation, called also secondary mitral regurgitation, which means that the valve itself is intact and normal structurally, but because of dilatation of the left ventricle and the left atrium, there will be dilatation, and this will affect the mitral valve, leading to secondary mitral regurgitation. And the use of transcatheter edge-to-edge repair by the mitral, like the mitral clip, is an option that has emerged during the last years. And as you see in this movie, this is the mitral clip that is used to treat patients with secondary mitral regurgitation. And in the ESC guidelines, it's a class 2A recommendation, should be considered in selected symptomatic patients. And the same guidelines presented an algorithm. Patients with secondary mitral regurgitation, you should do angiography to see if they have coronary artery disease, and then you will proceed to TEER, mitral clip, or LVAD or transplantation, or sometimes you'll do nothing, just palliative care. These guidelines are mainly based on this well-known trial, the COOPT trial, which studied patients or randomized patients to either continue with the medical therapy or adding mitral clip to medical therapy in patients with ischemic or non-ischemic cardiomyopathy, EF between 20 to 50%. They have severe symptoms. They have moderate to severe secondary mitral regurgitation and with hospitalizations. And you'll see from the COPT trial results that the use of mitral clip, according to these strict inclusion criteria, the use of mitral clip was associated with lower hospitalization and reduced mortality at 2 years. And not only that, even the 6-minute walking test and the quality of life scores were improved by the mitral clip in these patients. And the 5 years follow-up of the COPT trial showed again that using mitral clip in these patients had a good effect at 5 years as well. We leave the mitral clip and the secondary mitral regurgitation to talk about the use of mechanical circulatory support in advanced heart failure. And when we talk about mechanical circulatory support, we may talk about short-term mechanical support like the Impella, ECMO, the aortic balloon. I will not talk about them because they are indicated in acutely acute severe advanced heart failure like Intermax 1 and 2. I'll talk about the use of long-term mechanical support, which may be the left ventricular assist devices for patients with worsening left with only poor left ventricular function, or we may have biventricular support for the failing left and right ventricle, and sometimes total artificial heart for the failing left and right. When we talk about left ventricular assist devices, they are implanted in the left side, in the left ventricle, in the apical part. It will suck blood, will send it through the outflow graft to the ascending aorta. They need 2 batteries and the controller to control the pump speed. These pumps may give you a cardiac output of up to 10 liters per minute. The old ones, they were pulsatile, they were really large in size, and we needed to reoperate the patient all the time because of the different valves inside the system. But for the last maybe 10, 15 years, all of these devices now are only continuous flow devices, smaller in size, lighter in weight, and we don't need to reoperate the patients all the time. And the question that we usually face, why do I need left ventricular assist devices when I know that transplantation is the best option for patients with advanced heart failure? And the answer for that question is that a shortage of organs. Number 2, the waiting time for transplantation is really long in many countries. And number 3, the technology with LVAD has improved, and they are now competing with the transplantation regarding survival. So this is the waiting list in Europe. You see that the number of transplantations here in the columns and the waiting list is increasing all the time. How do these left ventricular assist devices work? It depends on the aortic valve opening. If the aortic valve is closed all the time, all the cardiac output will go through the left ventricular assist device. But if we have aortic valve opening, some of the cardiac output will go through the ascending aorta, and some of it will go through the left ventricular assist devices. What do these devices do for patients with advanced heart failure? Number 1, improves survival. Number 2, improves quality of life. Number 3, reduce symptoms. If you look at the old one, the older generation, the pulsatile one, which were really big in size, this is the rematch study that I referred to. Really sick patient, NIHA class 4, all of them were inotrope dependent. And at that time, only 8% survived at 2 years, 23% with left ventricular assist devices with the older ones. Now, the 2-year survival with left ventricular assist devices is 80% and above 80%. If we look at the survival on the right side with transplantation, the 2-year survival with transplantation is really very near the transplantation with LVADs. The 5-year survival, according to Momentum, with the left ventricular assist devices, about 60%, and the Elevate, which is the 5-year survival with left ventricular assist devices in Europe, showing again that the survival with these devices is more than 60%. Do they provide meaningful life prolongation? Yes. They reduce symptoms. Many of patients, whether it's a bridge to transplantation or destination, they will start with, many of them, they have NIHA class 4 or 3. With time, they will improve in symptoms. And what about the quality of life? Yes, they improve the quality of life. However, patients still have functional limitations, and there are many complications. How are these devices recommended, the left ventricular assist devices, according to the ESC guidelines? Well, they may be used as a bridge to transplantation, bridge to recovery, bridge to candidacy, or sometimes as a permanent solution, destination therapy. And as a destination therapy, permanent solution, the recommendation according to the European guidelines 2A recommendation, and according to the American guidelines 2A recommendation. What about the contraindications? There are a few contraindications, but those who do not work with advanced heart failure daily, they shouldn't sit and try to exclude the patient from LVAD or transplantation because of different contraindications. The patient should be referred, and we will decide who will go further to advanced heart failure therapies. Disadvantages of having left ventricular assist devices, as you see, this is the cable, the driveline going through the abdomen, and this is the risk for driveline infection, the risk for aortic dysfunction, for bleeding, for stroke, for device malfunction, for right ventricular failure. So LVAD therapy is still challenged by many hospitalizations, and this is the slide that showed that many of them still hospitalized because of heart failure or GI bleeding. And if we summarize the complications or the adverse events related to the use of left ventricular assist devices, early on, we have the hemocompatibility related, like thrombosis and stroke risk. Later on, we have the hemodynamic related events like right heart failure and aortic regurgitation. What's the most common causes of death in these patients? The neurological events. Few slides about transplantation. Well, indications: advanced heart failure, congenital diseases, refractory arrhythmias and angina, and sometimes we do retransplantation because of failure or rejection. The main cause of transplantation in men usually ischemic and dilated, in women mainly dilated. Contraindications, again, there are a number of contraindications, but you shouldn't consider only the contraindications when you are sitting outside a transplantation center. You should refer the patient for advanced heart failure therapies. Number of heart transplantations a year, they're usually between 5,000 and 8,000 each year. And as you see, the survival has improved in the different era. And the main reason for this improvement in survival is that we have more knowledge, we have good immunosuppressive therapies and multidisciplinary teams taking care of heart failure patients. And the causes of death, usually rejection, malignancies, infections, or graft failure. There are different causes of death in these patients. The last 2 or 3 slides, what about those patients who are not candidate for advanced heart failure therapies, we should consider palliative approach. And the palliative approach shouldn't be only in the terminal care, it should follow the patient during the whole journey of heart failure. And it has been shown that by applying palliative care to patients with advanced heart failure, we will see benefits in quality of life, we will reduce the patient's anxiety, depression, and we will improve the patient's spiritual well-being. So my take-home message is to you that advanced heart failure remains a major clinical challenge. Once guideline-directed management therapy is insufficient, we should go to advanced heart failure therapies. We should identify patients with advanced heart failure and timely refer them for consideration of advanced therapies. Impressive progress has been made with left ventricular assist devices. Heart transplantation is still considered the treatment of choice. Palliative care is indicated when patients are ineligible for advanced heart failure therapies. And thank you.
Thanks a lot, Dr. Najjar. This was really great. So we moved on from medical management with Dr. Kamal to beyond that, durable medical mechanical device and the tier. So we'll go straight away to the third talk, and then we'll do the question at the end. It's my great pleasure to welcome Prof. Raf Westenfeld. He's the Senior Medical Director and International Clinical Medical Affairs Leader of Abiomed or Johnson & Johnson. And to recently, he was the Chief of the Division of the Heart and the Emergency Medicine in the University, in the Cardiology Department in the University of Düsseldorf in Germany. The heart center there, he's the second largest center of heart transplantation and LVAD therapy in the Europe transplant. Prof. Westenfeld has more than 280 midline listed manuscripts. He has a fellowship even in nephrology. He is one of the PI investigator of the trial that he's going to kindly talk to us about tonight, which he recently published and presented, the Danger Shock trial. So it's a pleasure to have you, Prof. Raf, and the floor is yours.
Well, thank you very much for the kind invitation. I hope you can hear me now. Can you give me a brief feedback that you listen to me? I mean, that you can hear my words?
Yes, loud. All fine, all fine. Go ahead.
All fine. Okay, thank you so much. Okay, yeah, I mean, it's about the Danger trial, so it's a pretty focused talk, but I'm happy to give it, and I'm very curious for the questions you may have. I mean, at first, I have to tell you that it was an investigator-initiated trial, so it was not like Momentum or co-opt a trial sponsored by the industry. It was an investigator-initiated trial run by Jacob Möller. You see here on the left side, right? So we as a company, we couldn't tell him anything. Actually, this guy here, I took this photo immediately before he held the New England Journal talk at the ACC this year. The guy, the roadie on the right side, could say to Jacob, okay, if you want to leave the stage, go on the right side. And he could tell him more what to do than we as Abiomed could do. And nevertheless, or even just because of that, he was able to publish this in the most prestigious journal of today, that this pump worked. I have to disclose that I was initially a PI, as you already mentioned, at the University of Düsseldorf, and about 1.5 years ago, I moved as a senior medical director to Abiomed at a point where I didn't know the results of the trial. So I included 25 patients. I'm loving this trial, but when I made the transition, I didn't know what was going on there. And today, for this 20 minutes, I brought 3 little parts. The first one will be like, what are the general challenges of trials in cardiogenic shock? You already saw from the previous speaker some data on rematch, so positive trial, but not in shock. It was chronic heart failure. What I will give you the original of the slide at ACC that Jacob presented, in essence, not all of them, but it was a 10-minute talk. And then I brought with myself some Q&A, some questions I took up and recorded over the time since April, since the presentation was held at ACC, which I found worthwhile to discuss and which may lay the floor for questions you may have, or maybe even answer some stuff that you are thinking of. Okay, this is interesting. So what's the challenge of AMI shock? Holger Thiele once said, AMI shock, acute myocardial infarction shock, is Cape Horn of trials. I'm a salesman, and so I love Cape Horn, right? Cape Horn is usually the place in South America where the ships are meant to sink. And if all this blue area is Cape Horn, well, this is a picture of Cape Horn. I mean, surely you will make it this evening, right? And this is also at least a painting of Cape Horn, and you would say, okay, this may be no chance of survival, right? And here, a medical circulatory support system probably will not help you because you'll go down anyway. And like here, MCS will not save you either because you don't need it, and it may even hurt you, right? Think of you're on this ship, you probably just want to grab a cocktail, and if you have a lifeline or anything else, you may be in danger by this stuff that may help you in these kind of moments where you're in danger, but not already lost, right? Where you would say, okay, this is great that I have all my devices in place. And so we were targeting, or we would love to target in danger shock, this potential sweet spot for mechanical circulatory support. If you think of the metaphor of Cape Horn, which I really like. Given this background, we said, okay, we want to have a STEMI of the left ventricle. And we know that in STEMI of the left ventricle, 1 out of 10 patients will develop cardiogenic shock. And if you get shock, only 50% will survive. 50% will be dead. These were the background calculations. And so our idea was, okay, if you have LV, STEMI, anterior STEMI with cardiogenic shock, then the routine use of the impeller pump, which is here shown in the left ventricle, soaking blood from the left ventricle and putting it out in the aorta with a cardiac output of roughly 3.5 liters per minute, that these would rescue patients and will lead to lower mortality compared to standard care alone. Inclusion criteria was, you want to have an anterior STEMI. Indicators of cardiogenic shock were hypotension and hypoperfusion, giving rise to a lactate of more than 2.5. And the EF should be reduced. We didn't really force people to do an ultrasound. We say you want to have a reduced EF because our pump sits in the left ventricle. And certainly this stuff, the patient should be randomized as early as shock was diagnosed. So by this, if we stick to the metaphor, we would wanted to exclude the very, very healthy ones, right? We didn't want to see this sundowner patients. We would say we knew from databases and from registry data that the mortality in these kind of patients, when all this comes together and you get lactate only from reduced LV function, mortality is close to 60%. Then we had exclusion criteria. If somebody had out-of-hospital cardiac arrest and was still comatose, or he had out-of-hospital cardiac arrest before the ambulance, so before the probes came in, he had to be excluded. We certainly didn't accept RV failure, and if already any mechanical complication was obvious, like papillary muscle or an septum perforation, these guys would also be excluded. The main exclusion criterion that really made us last long was the comatose out-of-hospital cardiac arrest. And here, right, we wanted to exclude the ships that were already just going down, and these were certainly also not meant to be in our trial, which aimed at the sweet spot of MCS therapy. As you can imagine, inclusion was really tough. Inclusion was super tough. And in 2018, if we were in the same room, I would ask you and wait for your answer. Maybe some of you know what kind of trial came out. It was the IMPRESS trial. which should be called depress because it showed that impeller and cardiogenic shock, if you include all the ships that go down anyway, does not help. In 2018, I was invited by the Danish Society of Cardiology and I was sitting in Odense with Jakob Möller, and he told me, I can't do this any longer. I can't include for 15 years and then have a negative trial. I will stop. And I told him, no, you can't stop. Please let us help you. Why not including Germany in your really, really famous DanShock trial? And then you may even have you have the same study, but you may have a better name, right? And then we said, okay, if Denmark and Germany will go to danger shock, and then we could at least enforce a little bit the inclusion rate, and we finished after 10 years, which is still pretty long, right? And the primary endpoint was survival as 180 days, and in the control group, survival was, or mortality rate was 60%, as expected. In the treatment group, mortality was absolutely 13% lower with a number needed to treat of 8. So you had to implant routinely in STEMI shock 8 times in impeller and you saved 1 life. We'll come to this in a few minutes. This didn't come without a price, so there were adverse events. We observed more bleeding in impeller patients. We observed more limb ischemia. For me as a nephrologist, and I still believe that impeller protects renal function. In this trial, we saw more transient renal replacement therapy on the ICU in the impeller group, which was really a surprise. Is too positive, but this is how it was. And we saw some more infection, most likely related to the fact that you also end up with a plastic 14 French device in one of your legs. Nevertheless, we were able to write down that routine use of a microaxial flow pump, in this case an impeller, reduced death from any cause in patients with STEMI and shock. And whoever tried to send a paper to Ink Journal, usually it is just rejected right away. But usually you never can write stuff like routine use. They will all say you're greatly overestimating your data, but we could write this. And we certainly had to mention that it was associated with an increased risk of adverse events. So some Q&As I brought with myself before we go into the discussion. Well, absolute risk reduction 30%. Is that a lot? Well, think about it. It's huge, even if it doesn't sound like that. And as a reference, I brought the so far only positive RCT in shock, which was from 1999, even older than a rematch. We waited 25 years for a positive trial in shock. And in this 99 trial, as you all know, is similar size. Patients were randomized to Revasc versus just medical treatment. And medical treatment was pretty intense. Medical treatment was on both sides, in IVP, majority had pulmonary artery catheters, so it was really cool, but they were not revascularized in the majority of patients, right? And there are a few lessons learned. A, primary endpoint in that trial was 30-day survival and was negative, right? Imagine, we say standard of care in army is certainly revascularization, and we were unable to detect a difference at 30 days. Since it's an old trial, we have data from 6 months, 1 year, 6 years, and it's always like that. You have big time advantage if you do revascularization, as we always do, right? And the number needed to treat was 8. And you remember, I also said, well, if you use an impeller in these kind of patients, additionally, and in addition, your number needed to treat will be, again, 8 to save another life in these guys. And I'm really curious how the long-term survival will be affected by the use of impeller. And these are mainly the data that we claimed 180 days as our primary endpoint and not 30 days, because even in shock, it didn't make a difference. So why do we have higher replacement in higher renal replacement in the impeller group? Well, I just don't know. I mean, it's as I said, it's a surprise. And to all we know, in protected PCI, so when you use an impeller pump to make a complex PCI in a safe situation, so you use it prophylactically, then we know that it's associated in retrospective and in pilot trials with less kidney injury. And in shock, it may be a different story. We don't fully understand it yet. It could be that impeller is really harmful. By free hemoglobin, you have some hemolysis. I've shown you the bleeding complications, and if you want to protect the kidney by a pump, but if you lose big time blood, you certainly will get an AKI. It could be survival bias in the impeller group, right? If somebody is alive with a very advanced cardiogenic shock, he may have AKI and survive instead of being dead without a transient AKI use. But yeah, we're currently digging into the data, and we'll have a pre-specified analysis that will be there, PCT in Washington later this year, and we hope that we will publish it simultaneously. And we're certainly doing some mechanistic tests to understand fully what's happening there. What about the adverse events? Is impeller harmful in general? I've shown you this: bleeding, limb ischemia, renal replacement, sepsis. And the New England Journal forced us to put a number needed to harm into the trial, which was 6. I mean, I don't have to tell you that it's really a different game. If you say number needed to harm of 6 to get a transfusion of red blood cells versus number needed to treat of 8 to survive instead of being dead. But this is how the numbers look like. What makes me confident that we can really reduce it is that there are differences in the adverse events between hospitals, which are certainly not powered. And there are also differences in the adverse events rates when you compare countries, so Denmark and Germany. So I think we can really, by adapting best practices, we may really bring this down. And as I've already shown you, we are already, despite of these adverse events, we show number needed to treat of 8 for survival, and this may be even better when we address these side events. What do you hear often is the p-value is very close to borderline. Well, I mean, there are not many things in life that are black and white, right? Only a few things are really good that are black and white, like this painting on the right side. And p-values, right? You stay upfront what p-value will be significant in your trial. You will say what power you want to have, and it was all pre-specified. So a p-value is either there or not there. There's no in between. I don't care whether you call it black or white, but it is just black and white. There are no gray zones. You pre-specify your endpoints in a clever trial, and we met these endpoints, right? I already told you we expected a survival or a death rate, mortality rate in the control group of 60%, and we observed 59. This is super close, right? And maybe one thing more you already mentioned. Right now, interventionists always party and say, yeah, we're so great to do the danger party. What's that for surgery? Well, you've seen these curves already, right? The party actually, for me, also began with CV surgery when they did a trial with a number needed to treat of 2. 48% decrease in mortality, but in chronic, very advanced heart failure. And as we already mentioned, it was a pulsatile HeartMate XVE, a device nobody would use today, right? And so far, we as interventionists were just set up for failure. We've shown that IBP doesn't work. We've shown that impeller didn't work in 2017. I mentioned to you the DPRESS trial. Some weird guy came out and said, you know, in shock, opening up 1 vessel is enough. At a time point of 30 days, which is weird. I've shown you the data that we were unable to show that opening up a vessel at all is beneficial at 30 days. And we claimed that opening up only 1 is the best. And we certainly published that the ECMO doesn't work. So this is really something, right? Now, of course, when it comes to surgery, we will be interested in high-risk surgery. We will looking forward to understand, are there certain people that may be escalated from a CP in your groin to impeller 5.5 with an accelerator approach in cardiogenic shock? Because mean duration of support in danger was 60 hours, 60, which is pretty substantial. And last question I have for you, and then we can certainly discuss this, which, because these are here often in Germany, and I can't tell, I'm something in between surprise and angry, because people say, yeah, we have to do a second trial because this trial was 10 years and so much changed. This is a picture again from Jacob when he showed us the data in January in Danvers. And I remember that day because I was so happy I could not sleep that night. And you see up in front Jacob, and in the back you see the inclusion curve I've already presented to you. On the left side you see Jacob's son. When the study started, Jacob's son learned skiing in Austria. And you see somebody in the movie, like, you feel like, I'm not sure whether he'll make it to the bottom of the hill. I'm just not sure. And then on the right side, you see also a video of Jacob's son at the time when danger finished. And this Danish son of Jacob is currently a ski instructor in Austria. And you can imagine that he's really skiing great. And we tried to find differences in treatment of shock because cardiologists always hear for progress, right? And we couldn't find any difference. We did not find any difference in revascularization, even after carpet shock showed you should only open one vessel. We didn't see any change in outcome over these 10 years. So I would say, let's celebrate the first randomized controlled trial demonstrating that an MCS device, in this case an impeller, helps in acute setting of cardiogenic shock. Thank you.
Thank you. That was really, really great. At last, we've seen a successful mechanical support trial in acute cardiogenic shock. If you just bear with us, so we'll just go through questions for all the talks. I think
Yes.
that for you, Dr. Kamel, I think is why don't we simplify the classification of heart failure based on ejection fraction to divide below and above 50%?
Well, that's a very good question and a very controversial question at the same time. I know that the NICE guidelines divided it less than 50 and more than 50. They think that if you go all the clinical trials, most of the clinical trials were enrolled patients with ejection fraction less than 40% for the heart failure medications. We have solid evidence for dapagliflozin and empagliflozin for those who have PEF. But if you look at these clinical trials, it makes things even more confusing because they define HFpEF as more than 40%. It is making more confusing. I think we are still learning. We have solid less than 40% reduced ejection fraction. We know more than 50% is preserved ejection fraction. In between, I think we need to leave things for more research to be done for more things. Now, we know that between 40 and 50% that dapagliflozin helps, but will interest to help? There's plus or minus, probably is female, less than 53%, probably helps. Will spironolactone help in the TOPCAT study? There's a lot of things to research in this interesting group of patients. The other thing that a lot of patients with reduced ejection fraction will improve to mid-range, what we'll do for them. There's also another thing for research, but what we believe now, you need to continue the GDM medications for these patients, at least that's what I believe from what I know. So it's a very controversial. I still throw the ESC guidelines, but yes, the NICE guidelines put it less than 50, more than 50, based on some registry. And I think the evidence is not so strong to make it less than 50 and more than 50. I agree more with the ESC and the ACC.
What I know what I heard actually, they were trying to focus update on the European heart failure guidelines last year. They discussed this, and it was very controversial even in the meeting. Apparently, I think 75% actually wanted to change it to HFnEF and HFrEF, but they didn't reach the cutoff figure for agreeing, so it kept it as it is. But anyway, so
there is another thing. Will we call it HFnEF or HFpEF? Because will you call it heart failure with normal ejection fraction or preserved? Because although if we say normal, the people will think that the heart is normal, but that's not necessarily true. Even if ejection fraction went to up to 55%, for example, but there must be some I have a patient, for example, who came with me with heart failure of less than 40%. And with the GDM, she improved to more than 60%. When I did MRI of this patient, there is some scar on the heart. So I feel we need to call it more a HFpEF rather than a HFnEF. That's my opinion.
We have the issue of of fear of initiation guideline direct therapy during hospitalization. Actually, not only fear, but also downgrading when people come in with acute decompensation, and their kidney goes off a little bit or blood pressure goes off a little bit, and they end actually with less guideline direct therapy than we came in. I mean, how do you address this in your institute?
This is one of the common scenarios that come to me. So patients come to me with heart failure in the clinic. They are fluid decompensated, so I admit them. One of the very things that I speak to the nurses, the doctors, that don't stop giving them their medication. Give them, put them in the high dependency unit, give them diuretics, try not to initiate iron drop as much as you can, and try as much as you can to maintain, because the blood pressure is like, say 100/50 or 90/50 is because they are on medications. What they need now is to give them some diuresis and monitor them. And then they might, if they need some inotropes, for example, like noradrenaline, for example, or norepinephrine, I might reduce a bit beta blocker, but I don't tend to stop it, because if I stop it, I risk the patient going into VT, for example, during hospitalization. Not to mention that beta blocker effect may last longer. So even if you stop it for a long period of time, small period of time, you're actually not doing anything. Okay, and then you will again go back to the usual dose. So reducing it will not do any much of any effect actually, because the effect is already there in the body. So I need not to do that. No, so subset of patient who comes with when I start like furosemide, for example, the blood pressure really goes very low, so MAP goes below 60. In that case, I might reduce the doses, but not to stop, reduce the doses of my GDMT medications. Very rarely, if I need to stop beta blocker, for example, if I think they are in shock. But then I make sure that after I wean them off the inotropes and the furosemide, that before discharge, they're going back to the same doses that they were having before their admission, index admission. So yeah, you should individualize it to your patient. It's case by case by, but the keynote here, don't discharge the patient before he's back to his GDM medications.
My last question to you, Kamila, just before I move to Dr. Najjar, is the use of inotropes. I think you mentioned in your talk that you use your preference actually to go for norepinephrine as like a sort of first line, and then you add in milligram. Although I think a lot of people will actually, if the blood pressure is sort of reasonable, 500, whatever, 90, they will probably start with D-vitamin. You seem to go for norepinephrine first. What's your comment?
So what I do, if the blood pressure is soft, like if it is 100, that's fine. But a lot of patients comes to us with blood pressure of 80, for example, or 85. In this case, if I give dobutamine, I reduce the blood pressure further. I may aggravate things. At least reduce the perfusion further. So what I do norepinephrine. So the blood pressure goes slightly high, like up to 9500, and then I'm gonna give dobutamine. And then after that, I try to wean off the noradrenaline and keep dobutamine. Now, it's good to do right heart cath in these patients, because if you have high SVR in these patients, sometimes you may have to give some vasodilator. Here, milrinone might be better than norepinephrine or dobutamine in these patients. So you give norepinephrine and then milrinone, and then you stop norepinephrine and continue milrinone. And if despite that you do right heart cath, for example, for this patient, and you find that SVR is too high, like recently I added for the patient nitroprusside. And now we usually don't give nitroprusside for this patient because of low blood pressure. But if you optimize your inotropes and then the SVR high and you give nitroprusside, it will actually help diuresis and improve cardiac output. And by that, it might increase your blood pressure as well. So I think right heart cath is very important in cases like that. And again, you need to individualize it within your different patients. I used to give dobutamine as initial medication before, but I noticed dobutamine creating more arrhythmia than norepinephrine. So I noticed that. The downside of norepinephrine that you are giving sympathetic mimetic, so you cannot give beta blocker. But when I wean norepinephrine and the patient on Merinon, I don't have levosimendan, and the blood pressure is fine, I sometimes challenge them with small dose of carvedilol and to help me. And if the blood pressure is fine, thing is going on, then it helps me wean off Merinon and start the other GDMP again with very small doses. But I know if I start this and the blood pressure goes down or kidney function become worse or lactate went up, then this patient is inotrope dependent. So again, it depends on your clinical practice and how to do it. The problem that we don't have evidence-based management approach for those patients. That's the main problem. Most of them are excluded from clinical trials. So it all depends on your expert opinion and your experience throughout your years in managing these patients.
Thank you. Dr. Najjar, I'm just going to ask you a couple of things. First, about the TEER, the mitral valve clip. Which patient you will not accept, will not take? See, a lot of patients with the moderate severe MR, maybe the LV is not a huge dilated, but they have RV dysfunction, pulmonary hypertension. What are your sort of exclusion? Say this is I will not take, I will not consider for TEER.
Well, we usually discuss these patients in a multidisciplinary team meeting, including advanced heart failure specialists, including thoracic surgeons, and of course, TEER specialists. And we usually follow the co-op inclusion criteria. So those who are outside these criteria, we usually refer them further to do the advanced heart failure therapies. Sometimes we do it anyhow, even if the patient doesn't have all the inclusion criteria according to co-op. If we would like to have more time to do the investigations for advanced heart failure therapies. So it's always individualized. We have to discuss them in a multidisciplinary team meeting and to decide.
Okay, that's fair enough. You talk about the LVAD and the transplant. I know you mentioned the rule of 3 and the need to refer before your patients. But do you have? We see a lot of patients here. Actually, we know for certain they are, say, for example, they're non-compliant. They have really major social, psychological issues, and rightly or wrongly, sometimes we discuss, sometimes we don't discuss. So, but you seem to say, would you? These people should be referred, and then, and then you filter them, rather actually filter it before they come to you.
Yes, what we usually do, of course, if you have a non-compliant patient, the non-compliant patient will be excluded. But when the patient is referred from a secondary hospital to a tertiary hospital to be considered for advanced therapies, we have a team of different specialties, like the psychologist, the social workers, the LVAD coordinator. We will meet the patient many times. We will do the investigations, and then we will discuss the patient again in a multidisciplinary team. So sometimes, for example, the right ventricular failure for LVAD implantation, we usually accept TAPSI down to 7.5 millimeter. 7.5 millimeter for many clinicians, cardiologists, is too low, but we accept that if the hemodynamic evaluation shows a good right ventricular function. So I mean, yes, non-compliant is a problem. If they don't have a social network, it's a problem, but they deserve a complete assessment by a specialized team. This is how we look at the thing.
Dr. Najjar, just remind us about the presence of valvular heart disease in patients that you consider for LVAD. Again,
yes.
AVR, whatever. So what are the sort of contraindications for people that you will not take, and maybe you have to replace the valve first, whatever? Just give us what are the audience.
The most important one is the aortic valve, because if you have aortic regurgitation, there will be a vicious circle. The pump will suck the blood, send it to the ascending aorta. It will be back to the through the aortic valve. So we usually do aortic valve replacement for the aortic regurgitation together with the LVAD implantation. Aortic stenosis is accepted because the patient will be dependent on the LVAD. Mitral regurgitation will improve by unloading the left ventricle, so we usually accept all the degrees. The tricuspid regurgitation is controversial. Some clinics will do the ring operation with the LVAD implantations. Others will accept the tricuspid regurgitation. So the most important one is the aortic regurgitation.
And probably the last one, we see a lot of patients with advanced heart failure come to us already have a cardiovascular syndrome, some liver dysfunction. At what stage you say this is not for LVAD? I mean, would you give them a trial of anatropes? How do you handle this patient? You potentially have reversible.
When we have a patient with a cardiorenal syndrome with the eGFR between 20 and 30, what we usually do, we give them levosimendan to see if there is some reversibility in their kidney function. And if we see some reversibility in their kidney function, which means that it improves after levosimendan, we usually give them the LVAD, because LVAD will improve perfusion to the kidneys, and they usually will survive without problem. But if the kidney function is below 20, we usually don't accept them. This is for the LVAD. For transplantation, we may consider heart transplantation first and then kidney transplantation later on.
Perfect. Just for sake of time, we'll move to Prof. Raf.
Yes.
Please, Dr. Kamil and Dr. feel free to ask question too. I was really impressed by reading the trial before this meeting, I have to say, and also listening to your great talk. So, even ECMO failed, everything's failed in post-myocardial shock, but this trial seemed to be positive. Yes, it took 10 years. What do you put down the success of the trial due to? Is it the selection of patient? And
yeah, you got a good point. My gut feeling is that it relates to this selection of patients. I was really struck years ago by the rematch trial. I mean, it was performed by CV surgeons, at least majority of them, right, which are not super trialists. They are not Greg Stone all the time, and they had a nomenclature of 2. And I always said, like, in army, the slope of the patient from being referred to you and being dead is very steep. And so the chance of meeting somebody where you say, I want to save his life, but who's really on a sliding scale and will be dead in 20 hours or even earlier, right? In the control group, the death happened after 13 hours in mean on the ICU in pump failure. So I think this is really, really quick, and you have to be very, very careful whom to accept for a trial and whom to exclude. And you can certainly criticize it, but if you want to prove something, in basic science and also in patients, you have to have a very clear-cut idea of whom to include. And I think this was the key, and this was the miracle of the trial.
Yeah, I was also slightly surprised, as you said yourself, by the sort of the harm, especially the renal replacement. Sorry, was higher in the treatment arm, in the umbrella arm, when you expect with reperfusion that the kidney will get better. Again, just your comment on that.
Yeah. So, I mean, you have to. These dialysis was transient, so today nobody is still on dialysis. So it was acute tubular necrosis, even if we didn't have any biopsies in a single of those patients. And it wasn't certainly a good thing to have AKI and being on renal replacement therapy. So when you look at mortality, it increases even in the impeller arm. In the impeller arm, you have a high mortality when you have AKI by numbers, and you have an even more increased mortality when you have AKI by creatinine numbers and renal replacement therapy compared to controls. But by numbers, your mortality is still lower if you have an impeller, have AKI, have renal replacement therapy, than somebody who doesn't have an impeller and has none of those, right? So the difference is there, but it's still better to have the pump on board. And I hope we can decipher a little bit what's going on there. I'm not so much convinced that it's free hemoglobin, but it will be hard. I had this idea, maybe, you know, the time from symptom onset to randomization in the trial was 3 hours. And now imagine you're a kidney at low output. My gut feeling is you try to make every drip of blood and turn it into GFR, right? So you will open up big time your vas efferents, and you will constrict like crazy your vas efferents. And then you're randomized to control, and this is to impeller. This means that you really kick in with high time perfusion, because you also, even in a healthy kidney, when you in a healthy heart, if you turn up an impeller and measure kidney perfusion by augmenting diastolic perfusion, you augment perfusion by 30%. And my gut feeling is that maybe something is happening, that we blow up the kidney, which at a state where the kidney wanted to rake to low perfusion pressures, but I don't have any proof of that.
My last one question to you about the trial. It mandates that the lactate has to be more than 2.5, but the result, actually the benefit, has no relation to the level of lactate. So again, how you square that?
Okay. This is this may be a question I will put on the slide, right? In the Q&As. I mean, the lactate is, in this trial, the lactate was always the consequence of left heart failure, right? If you see a lactate in all the other trials, in the majority of patients, lactate is much higher, and it is coming from resuscitation, right? If you lay it someplace and you don't have an LV problem, your lactate may be 7, but your lactate is not a problem because your heart hasn't a problem. And here we are sure that the patients all have a heart problem. Lactate may be higher because 50% were also resuscitated. So I feel like this lactate level of 2.5 was just cut off to make sure that we don't include the boats which are on the nice journey around Cape Horn and should go for cocktail. This was the 2.5 lactate. But once your lactate is above it, and if every other guy has been resuscitated, your lactate is all over the place. So I think the cutoff is just a cutoff, and beyond this, it's not a continuous variable. This would be my gut feeling on that.
Hey, I will try to do a summary at the end, but I would like to give a chance for each of you to have just a final comment. So start with you, Dr. Kamal. You're muted, I think.
Sorry for that. I just want to say that heart failure is a disease which is really malignant, with high burden on healthcare services and high mortality and morbidity. We need to take it very, very seriously. I think you need to start the guideline-directed medical therapy as soon as possible, and try your best to avoid the patient to go into advanced stage, okay? And try to delay it as much as you can, so that the patient get better life, better quality of life, and better survival, and don't hesitate to go to advanced to devices or any advanced therapies whenever it's appropriate.
Thank you. Dr. Najjar, please.
Please identify patients with advanced heart failure by looking at the clinical clues like frequent hospitalizations and refer them to Advanced Heart Failure Center to consider them for advanced therapies. Thank you.
Prof. Raf, do you have any comment before I do my little summary?
Oh, yes. Oh, yes. Thank you for the invitation. And please remind the number needed to treat of 8, which is similar of opening up a vessel. And I recall my times when I was interventional cardiologist and I opened up vessels at a feeling like it was me against the vessel. And I would not stop before this vessel was open. I would call somebody else, and if I couldn't make it open, and I would try as long as possible. And I might even call a surgeon. So the results are pretty strong. And if you want to save your patients, consider Revasc and shock and impeller as a therapeutical valid option.
Thank you. I'm really honored and I'm glad, and I appreciate all of you giving the time for this evening. I will just do a little summary. Really, we've learned tonight a lot. We reminded ourselves the importance of guideline diagnostic therapy, the early initiation, the quick up titration, the use of CRT for patient indicated from Dr. Kamal. Dr. Najjar reminded us about the importance of recognizing advanced heart failure, not to confuse yourself. You can use the I need help acronym, but there's a rule of 3. The patient get recurrent admissions, they need more diuretics, not tolerating or de-escalating guideline directed therapy. This is the time to call and to refer for advanced therapy. We made such a huge improvement in durable medical devices. Survival 2 years, 80%. Can you believe it? It's really trying to compete with the transplant, which is the gold standard, which unfortunately, as the figure shown by Dr. Najjar, they're static around 5,000. Really, the number, we don't have enough donors. So, but we may just advance in the durable devices. We can use even as destination therapy, not just as a bridge to recovery, bridge to transplant. We're learned from Prof. Raf about now. There's a positive trial in the mechanical circuit support and acute myocardial infarction shock and the use of Ambella. And I'd like to thank everybody. For the audience, you please need to complete this survey in order to get your CMEs. And I'd like to thank all the speakers. I really appreciate it, and I was really great, one of the best. And I'd like to thank you all, and good night.